gender, age, downtime with time to ROSC below or above 25 minutes, initial rhythm being non-shockable or shockable, or whether they had circulatory shock at admission, and it was no difference between these groups. This is a quite important slide from the results of this trial. These are the modified Rankin scale categories on top of each other, and you can see the hypothermia group on top and normothermia below. And for every category, from no symptoms down to severe disability and then to death, there was no difference, exactly the same distribution throughout all these scores. We had one significant finding in the trial, which was otherwise very neutral. We found that there were more arrhythmias causing hemodynamic instability in the hypothermia group compared to the normothermia group, 24 versus 17%. And these are actually some numbers that others have picked up that we did not present performing any statistical analysis, but it's been done post hoc. There were more time receiving invasive mechanical ventilation in the hypothermia group compared to the normothermia group, 3.8 days versus 2.9 days. And there were more than twice as many unexpected severe adverse events, 3.7 versus 1.4%. These numbers were not part of the original publication. So if you put this trial in perspective, I think it's just good to see the number of patients that have been randomized to either hypothermia or normothermia, at least the larger trials. And on top you see Bernard and Haka from 2002, and then the Hyperion trial that came out a few years ago. And then we have the TTM1 trial and the TTM2 trial. So you can see from 77 patients to start with, 275 in the Haka, up to close to 600 in the Hyperion, 950 in TTM1, and 1,900 patients in the TTM2 trial. And if we compare these trials in terms of cardiac arrest characteristics, there's been a lot of discussion about the high number of witnessed arrest in the TTM2 trial being 90%, but for the Haka trial it was 98, the Bernard had 95, the TTM1 trial had 90%, and the Hyperion trial had 94%. So very similar in terms of witnessed arrest or not. Then it comes to the bystander CPR rate, which was 80% in the TTM2 trial, compared to 73% in the TTM1, 62% in the Bernard, and 46% in the Haka trial, which are lower, of course. But I think we can see that trials that are later, they have more bystander CPR, and that's proven by the Hyperion trial that actually had 70% bystander CPR reported. And for the downtime, we reported 25 minutes from cardiac arrest to return of spontaneous circulation in the TTM2 trial. In the Haka trial, it was 21 to 22 minutes. The Bernard trial had 25 to 26 minutes. In TTM1, we had 25 minutes, and the Hyperion trial had 17 to 19 minutes. So I think they're quite similar. All of them have a substantial ischemic event, at least in median. But of course, these trials, they comprise both those with shorter arrests and those with longer arrests. Another point that's been discussed quite a lot based on the findings from the TTM2 trial is the time to cooling. It's been out in the social media sphere that it was a very long time down to reaching target temperature in the 33 group, and that would be the reason for the neutral result. But then I just would like to remind of the Haka trial, and these are the TTM2 trial numbers on top of the Haka trial, which was the first positive trial. And as you can see, we were few hours actually faster and with a steeper trajectory down to target temperature of 33 degrees. So I think speed of cooling was up to par. And if you compare that to the TTM1, Hyperion, TTH48 and Princess trials, it's about the same, very similar to large registries and case series, but admittedly a bit slower than the Bernard trial and the Capital Chill trial, one older and one recent. And this is my last slide, because I think it's also important to discuss this, since that's the other big thing that's been brought up after the release of the TTM2, and that's whether the patient group was sick or not, and whether a sicker population or a less sick population would have the same outcome, the same null difference between hypothermia and normothermia. And as you can see here, we have plotted the baseline risk of death using propensity score matching with a predicted probability of death throughout the span from very little risk to very high risk. And as you can see, there is absolutely no difference throughout the span of baseline risk for these patients in the TTM2 trial. We had those that were severely sick, we had those with a milder injury, but it's important to realize that all were comatose, and the median time to return of spontaneous circulation was 25 minutes. So I think we captured quite basic general population, and that the trial results therefore should be relevant for the cardiac arrest population. And with that, I would like to say thanks, and I'm happy to discuss this for the hours to come.
Thank you, Niklas. Are there any pressing questions on the Q&A?
I don't see any questions for now.
I've got a quick question, Niklas. What about rhythms, shockable or non-shockable rhythms? Any signal for those?
No, I can just move back here to see if this is a little bit, oh, wow, now it's fast. But you can see initial rhythm, non-shockable and shockable, and you can see that there is no big difference here. And we had about 500 patients non-shockable. And we are actually, for the moment, performing individual patient data meta-analysis together with the Lascaroux group in Nantes in France to have all the non-shockable patients in one analysis.
Right, thank you. Thank you very much, Niklas. We'll ask you some more questions later in the discussion. So I'm going to hand over to Natasha to introduce the next speaker.
Thank you, Jas.
And introduce herself as well.
Thank you. I'm Natasha Spartinou. I come from Greece, from Heraklion, Crete, actually. And I have the honor to introduce our next speaker, who is Professor Jerry Nolan. He's a consultant of anesthesia and intensive care medicine at the Royal United Hospital of Bath, and also a professor of resuscitation medicine at the University of Warwick, and also the editor-in-chief of the Resuscitation Journal. And I'm really happy that he's here with us this night in this webinar, and I think the floor is yours, Professor Nolan.
Natasha, thanks very much for that kind introduction, and thank you for the invitation to speak to you today. Hopefully we should have, let's just put that to screen. So hopefully you can all see that reasonably clearly. So I'm going to talk about the ILCOR systematic review that was done a very short time after publication of TTM2 that Niklas has so very nicely presented to you. We were obviously expecting the results of TTM2 for a while, so we had a lot of this kind of set up beforehand, really. This is the publication in Resuscitation. Let's just hide that that you can see there that appeared in Resuscitation in 2021. The group was kind of led, I guess, by Lars Andersen and his team, although Jazz and I are also co-authors on this. What I've done is, rather than go into the sort of lengthy discussion around the methodology that was used, I've just sort of set out the key 6 PICO questions that were addressed and that searches were set up for. And what I'll do is try and give you just a little bit of data relating to each of those 6, but the major focus is going to be on the first one. And for that reason, I'm actually going to show you the details of the actual PICO question you can see hopefully there. So we were looking specifically at adults in any setting, so in or out of hospital. The intervention was TTM, which we define as TTM studies targeting hypothermia at 32 to 34. And the comparator was no TTM. So in other words, studies either targeting normothermia or fever prevention. And then outcomes or any clinical outcomes, as you can see. It's just. So if we look at, first of all, addressing this first question, you can see there were 9 trials. They're mainly out of hospital cardiac arrest, and the control group temperature varied between 36.5 and 38, as you can see there. I think it's important to if you scan down, you can see there's only 3 of those studies. That's the HACCR 2002, Lascario, the Hyperion trial 2019, and TTM 2 that actually included more than 100 patients. And many of these other studies were actually pretty small, as you can see. This is really just the bias assessments to give you an idea of what those look like. And I just would highlight, I guess, in terms of randomization, high risk of bias in the Callaway trial, in the Bernard trial, which was published the same year as HACCR, and then indeed also for the Zhang trial there. So that gives you, most of them are intermediate risk of bias, but with 3 being high, the 3 that I just pointed out, as you can see. So I guess I should apologize for the number of forest plots I'm inevitably going to show you, but it does give you, I think, a very good overview of the kind of, I guess, signal produced by the meta-analyses for these studies. This is specifically 32 to 34 versus normothermia. And you can see here for survival to hospital discharge, no significant difference, although signal is trending towards TTM at 32 to 34. These were randomly done for these forest plots. And one thing that I need to point out is that it tends to favor the smaller studies for reasons which I'm not being a statistical expert, I'm not entirely clear about. But if you look very closely, you've got by far the biggest study, TTM2 here, then lots of relatively smaller ones, which have got quite a significant influence in terms of shifting that in that direction. I'm just pointing that in detail because it's slightly odd in some ways. And then we've also got favorable neurological outcome of 30 days, as you can see, very much the same with wider confidence intervals. And then if we look for the next slightly longer term outcomes, 90 or 180 days, and then favorable neurological outcome for that 90 to 180 days as well. Pretty well the same thing if you scan down. So no significant difference, if anything, swinging further towards the null, as you can see. So one of the things, there were lots of sensitivity analyses done with this systematic review and meta-analysis, but I think the key one was to include 36 as in the normothermic range, because you can argue that 36 actually is within the definition of normothermia. So that then meant we included Niklas's TTM1 study as well. And that, of course, just tightens things up even more. And if you look at survival, I've just shown you survival to 90 or 180 days and neurological outcome for that period as well. And you've got, certainly for survival, very much towards the null. Or again, but although favorable neurological outcome is slightly trending towards the cooler group. So that was the analyses for that hypothermic temperature versus normothermia. There are some studies looking at different temperature targets, so different kind of values for hypothermic temperatures. And to cut, these are the 3 studies that we came up with. And the bottom of the slide, you can see down here, these are all out of hospital cardiac arrest studies. And the bottom line, there was no difference in outcomes. There was no meta-analysis done of these, because they're all very different studies. Timing of targeted temperature management was one of the other PICO questions that was addressed. This is largely in effect, if you scan down the interventions here, they're nearly all, it's all bar one of these, is essentially pre-hospital cooling versus not pre-hospital cooling. So 10 of the 11 trials, as you can see at the bottom of the slide, are basically picking up that. And I think it's probably quite useful if we look at the forest plots for these. These have been divided into post-arrest cold IV fluid, intra-arrest cold IV fluid, and then intra-arrest intranasal cooling. So they're all kind of very different interventions. Overall, if you just come right down to the bottom of the plot here, you can see absolutely sits bang on the null, so right on the one, so no benefit whatsoever. But if you scan further up, post-arrest cooling, if anything, that signal is slightly favouring no pre-hospital treatment. Again, intra-arrest, no pre-hospital treatment, and it may just be the issues around high volumes of cold fluid may actually be potentially harmful, and there was some signal of that in some of the individual studies. I think the one group that's interesting, and I'm sure we will hear more about this, and I'm aware from recent presentation by Fabio Tacconi in Brussels last week that they are planning a future study of intranasal cooling, focusing specifically on shockable rhythms, because if you look very closely at these two studies, there is quite a strong signal suggesting benefit for pre-hospital cooling. And of course, this is the one group where you're getting cooling during cardiac arrest before ROSC, but not using high volumes of cold fluid, which may actually be in themselves detrimental. So that's an interesting group to consider for the future. Cooling methods and duration. There's quite a few studies here, but look at the size of these studies. They're all, except for one here, pretty small, and there's one study on duration which is tagged onto this table, as you can see. So we have got a meta-analysis with a forest plot for endovascular versus surface cooling, which interestingly, although it's not significantly different, does actually give a very sort of strong trend of a signal. I keep using these slightly dodgy, statistically dodgy terms, but potentially favouring endovascular, but not statistically significant. And this, of course, was the one study looking at duration of cooling. And this was essentially 24 versus 48 hours. And I'm sure many of you are aware of the results of this. Again, no significant difference in the primary outcome of favourable functional outcome at 1 to 2 at 6 months, as you can see. So an important point to make just before I give you the kind of treatment recommendations that ILCOR came up with is, I think a really important concept is that we're trying to move away from, although I've been talking about the term TTM because that was used in the original systematic review, but it's probably much better to use the term temperature control, because that avoids confusion with the specific studies that Niklas has been discussing, the TTM1 and TTM2 trials. And so we've got hypothermic temperature control, normothermic temperature control, fever prevention temperature control, and no temperature control. So that gives you all the different kind of possibilities without confusing with the specific trial terminology. So in terms of ILCOR treatment recommendations, and Jazz will know because he kind of headed up a lot of this discussion, there was a huge amount of debate about this. But the key one is that we suggest actively preventing fever by targeting a temperature of less than or equal to 37.5 for those patients who remain comatose after ROSC from cardiac arrest. And that's a weak recommendation, despite all that evidence. It's still a weak recommendation, low certainty of evidence. And then this is the controversial one, because it's not really a treatment recommendation at all. And it's the statement that whether subpopulations of cardiac arrest patients may benefit from targeting hypothermia at 32 to 34 remains uncertain. And I have to say it's controversial because there is still a very large body of experts around the world who still firmly believe that there are some populations of patients that may benefit from this. Well, it has to be said, the evidence for that is pretty scant. And then comatose patients with mild hypothermia who spontaneously cool after return of spontaneous circulation should not be actively rewarmed. And that's just a good practice statement because we still don't have good evidence for that. And then we suggest surface or endovascular temperature control techniques. And you've seen that forest plot showing no significant difference, although trending towards endovascular. And that again is a weak recommendation, low certainty. And then this one is a simply a good practice statement because we don't have good evidence, but the statement is when a cooling device is used, we suggest using a temperature control device that includes a feedback system based on continuous temperature monitoring. It's a sort of expert opinion. We don't have hard evidence one way or the other. And then we suggest active prevention of fever for at least 72 hours in the post-cardiac arrest patients who remain comatose. That's kind of the standard of practice now, but they really don't have evidence for that. And I know that's something that may well be addressed in TTM3, but that is a good practice statement. And then the final one is based on one particular study showing potential harm from pre-hospital cooling with rapid infusion of large volumes of cold fluid. So we're actually suggesting against that. Ironically, it is the only statement for which it's a strong recommendation of moderate certainty of evidence, which is perhaps slightly disappointing. So with that, I will conclude. I'm very happy to take any questions now. I'll actually stop sharing so I can see the rest of the team.
Thank you very much, Professor Nolan. As I can see, there's no questions related to your presentation for now at Slido. So if I may ask one, what do you think is the most important question to be answered in the next few years?
Well, I mean, I think, and Niklas is smiling because hopefully he's going to answer it with TTM3, which I've said all along with all those treatment recommendations that we're uncertain. We really don't know whether fever control is better than essentially no temperature control, and I do think now that there is probably sufficient equipoise globally for clinicians to want to randomize patients into such a study. It's important that we do that. So that's one question that I know TTM3 will be addressing. So, and I would certainly support that.
Thank you. So I think now it's time for Christian.
So Tino will introduce our next speaker. So introduce yourself first, Tino.
So welcome to this webinar again. My name is Tino Greif. I'm a professor of anesthesia and intensive care medicine, living and working in Bern, Switzerland. And currently I'm the ERC director of Guidelines and ILCOR. And I guess this is the reason why I was invited to moderate this. It's a pleasure for me to introduce Christian Hassager. He is a professor of cardiology in Copenhagen at the university there. He works at the University Hospital in Copenhagen. Christian volunteered in leading positions in European cardiology societies and also in Denmark societies. He was also the chair of the Denmark Resuscitation Council. And his research focus is on cardiogenic shock and post-operative resuscitation care. So he's maybe the best person to tell us a little bit about the effects of hypothermia on the entire cardiovascular system. And with any further ado, please, Christian, tell us what's going on the cardiovascular system.
Thank you very much, Tino. I will skip a little more, not so large trial, what happens there, but try to dig into what actually happens with the cardiovascular system. I will try to talk about what happens with hypothermia in the blood vessels, in the electrical part of the heart and the mechanical part of the heart, and then at the end see what it actually results in the circulation. We have to go back many years, more than 60 years, to see some of the first physiological studies in circulation. What happens? They took some anesthetized dogs and immersed them in ice water. And what was quite clear, this is % of the initial vascular resistance, both in the systemic and the pulmonary vessels, they actually contracted. You had a much higher vascular resistance when you cool down the dogs. They were sedated. There was also a study in Nature in '65 showing that the total peripheral resistance in these not sedated chickens actually increased the total peripheral resistance. So the vessels contract when the body is cooled down. Then what about the heart muscle? That's a little more difficult to study, but we have a 20-year-old quite good study where patients who were electively going through bypass surgery, they when they were sedated, they did pressure volume loops on the left ventricle, a way to measure both the pressure inside the ventricle and the volume of the ventricle, and by that they can estimate the contractility and the elastance, which is a measure of that. You can see here when the patients were 37 degrees, 10 patients, and then they were cooled down before the surgery was performed just for this trial. And you saw a much less, lower elastance. And what is more interesting is actually in the only 10 patients, what we saw, or what was shown was that if you pace the patient at 80 or pace them at 120 beats per minute, you will normally see an increase in contractility. But when you had the patient cooled down, you actually saw a drop in contractility. So if you think you have a poor cardiac output and a poor functioning heart, if you have cooled down the patient, it's probably not a good strategy to just increase the frequency, for instance, with a pacemaker or chemically. Now, we're all interested in knowing what actually happens with the electrophysiology of the heart, because as Niklas just showed minutes ago, in the TTM2 trial, they saw more arrhythmias in the hypothermia group. This is a table from a paper showing all the different things that happens with the heart when it gets hypothermia. I will try to take some of the few more interesting things here. There's no doubt that you decrease the heart rate. That was shown already in the Nature work 60 years ago in chickens that we just saw. And actually, in the first TTM trial, we had the possibility to study this is the temperature curves, and over here the heart rates, and you can see 36 degrees versus 33 degrees, and here you have the cooling 24 hours. You see the pulse rate is about 10 beats per minute lower when you cool the body down. But it's a good thing. And this has been shown by many people. This is just one from our group showing that even whether you take minimum heart rate or average heart rate when you cool patient, it's strongly linked to the prognosis. So a normal heart and a normal brain should actually decrease the heart rate when the patient is cooled down. And if the heart rate doesn't decrease, you have a very poor prognosis from cerebral damage. There are two other things in electrophysiology when you cool patient. One is the Osborn wave or the J wave, which is shown here in a patient who was accidentally cooled at 27 degrees, a large wave here, decreasing here and disappearing at 36 degrees. This is called the Osborn wave, and this has been related to arrhythmias. We also had a chance to study that in the TTM trial. And as you can see here, we had the 36 and the 33 degrees group here. And we had a lot more, Osborn waves was a lot more common in the 33 group. But again, that's a good thing. Those who actually developed the Osborn waves were doing better than those who did not. And the reason is that this is a normal reaction to cooling down. And you don't have that normal reaction if your body is very damaged or brain, where they come from. The last electrical thing I will talk about is the QT interval. You all know that long QT intervals are dangerous for all drug companies. They're always very afraid that the new drug will prolong the QT interval. All drugs has to be tested for this to be sold on the market, because long QTs are usually prone to get a VF. Here is just one patient from our ward. This is pre-hospital, coming into the hospital, and then later on at cooling temperature, you get this long thing. This is how his ECG really looked. Everybody can see that the QT is long. Let's see what that means. In the TTM1 trial, just to show you, the QT prolongation was not just due to the cardiac arrest, it was also due to the cooling, because here you have the 33 degree, here you have 36 degree, and this was much more long QT was much more common among those who were cooled down. As you know, QT also depend on the heart rate. So this is the raw data out here, and then there are two different ways of correcting the QT depending on the heart rate. And whatever way we corrected it, QT seemed to be prolonged by the by the cooling. But I do have one good thing to mention, and that's just a new paper we did 6 months ago. And that is that the QT interval can actually be even further subdivided in a Q to T peak or T peak to T end. And this here is usually not very related to prone cardiac arrest, prone ventricular fibrillation, while the end here, the TP max to end, is more related to it. And when we looked at the TTM trial, we can see that it's mainly the QTP that is prolongated by the cooling, not the end. And this actually mirrors very well what we see in clinical practice. Once the patient have been cooled down, we rarely see re-arrest if they are fully revascularized and so forth. So it's probably not a dangerous QT increase. What about real clinical arrhythmias? Let me first say that in the TTM1 trial, where we had a lot of, where we had a subgroup that was on telemetry, we saw more electrical topical beats in short after the hospital, and it actually was more prevalent in the 33 group than in the 30-60 group. They cleared it faster, and this also mimics what they found in a much larger scale in the TTM2 trial, a 50% higher rate of arrhythmias that resulted in some sort of hemodynamic compromise. So getting down to 33 degrees may not give you a lot of ventricular fibrillations, but it does give you some arrhythmias. Finally, a few notes on the cardiovascular effect in total, in cardiac output and so forth. Let me take you 20 years back. The Bernard trial, the smaller study of the two ones in the 2002 trials, actually also had Swan-Ganz catheters in some of their patients. And what they saw was very similar to what was published in the hens and the dogs many years ago. The patient at 33 degrees had a much higher systemic vascular resistance than those who did not cool down. And this resulted in a quite a lot lower cardiac output, cardiac index here than the normal or hyperthermic patients here. So cooling down patients, remember the Bernard was only 12 hours, reduced the cardiac index, increased the systemic vascular resistance. We have actually also looked at that in a subgroup of the first TTM trial in 171 patients from our ward. And there we saw this, the first slide here is the temperature just, but we actually saw that the systemic vascular resistance was a lot higher in the cooled patient. The pulmonary vascular resistance was higher, both resulting in cardiac index instead of 2.5 going down to about 1.8. So my key messages from what happens with hypothermia on the cardiovascular system is that we do get an increase in the systemic vascular resistance, also in the pulmonary vascular resistance. We get vasoconstriction, and actually, which I have not touched upon here, you may also have, if you're very cold, some sort of dehydration because of cooling diuresis if you're not careful, and you may change the blood viscosity, but vasoconstriction is at least there. We have a central pooling of the blood volume. I've not had time to come into that. We definitely have a decrease in heart rate, which is a good prognostic thing. We may have some depressed myocardial function, actually. That's the study in the CABG patients. We have more arrhythmias, not a lot of ventricular fibrillation, but we do have some more arrhythmias. You have to go even lower to get VF in cooling. Going down to 30 degrees probably doesn't do anything. And then we have quite a pronounced decrease in cardiac output. I'd like to leave it here, and thank you very much for inviting me to this talk.
Thanks, Christian, for this nice overview on the pathophysiological mechanisms of hypothermia. There are no real burning question. Maybe for the transition one, you started to talk at the end, telling us 33 degrees or maybe 30 degrees are not dangerous for you. When does it start to be dangerous? Because a lot of people might have patients with accidental hypothermia. So what are the points for you? I can
tell you a little bit about a few studies. If we take the first one where they sedated the dogs 60 years ago, they actually cooled the dogs down until they died, and they started to die median at 21 degrees, very low, but with a wide range, but no cardiac arrest before 26 degrees. We had an accident in Denmark exactly 10 years ago where 14 youngsters capsized, and 7 of these had spontaneous circulation when we caught them out of the water. And they had a body temperature between from 23 and up. And the ones with the cardiac arrest, when found in the water, had 15 to 20. These are healthy hearts. And I think healthy hearts, you have to go down below 27, 26, something like that before you see cardiac arrest. But it may be higher in patients with coronary disease and so forth. But going down to 30 degrees will really not worry me.
Okay, thank you. And with this, I would like to make the transition to Anna Pichman, which will present the next speaker. Anna.
Thank you very much, Tino. Hello, everyone, and a welcome from myself as well to everyone who's joined the webinar. I'm Anna Pichman, and I'm the Vice Chair of the Young ERC Committee, and also an anesthesiologist at the Charité University Hospital in Berlin. And it's an honor to introduce Professor Claudio Sandroni, who is a professor of intensive care medicine at the Catholic Hospital in Rome. And he's got multiple hats on, but one of the key ones is that he's in the ALS task force for the ILCOR and also part of the editorial board of the Resuscitation Journal. But an interesting part as well, he's within the European Society of Intensive Care Medicine, he's the chair for Trauma Emergency Medicine section. So he's going to be talking about the European Rapid Guideline on temperature management after cardiac arrest, and all the questions after that we can discuss further. Thank you.
Thank you for this nice introduction. These guidelines, as anticipated in the introduction, have been co-issued by both the European Resuscitation Council and the European Society of Intensive Care Medicine, or ECM, and they have been published simultaneously in their official journal, Resuscitation, as you know, and Intensive Care Medicine at the same time. We have to produce these guidelines very quickly because, as you are probably aware of, shortly after the publication 1 year ago of the 2021 guidelines on post-resuscitation care, also co-issued between ERC and ESICM, the TTM2 trial came out, and this triggered a complete review of the evidence concerning temperature control after cardiac arrest. And so, as we generally do in ILCOR, we review the evidence for a quick evidence update, but this had to be done by both ERC and ESICM. Fortunately, the process has been facilitated by the fact that the European Society of Intensive Care Medicine, as ILCOR, also has a quick process to speed up the review of evidence when new evidence comes up, and we need to update very quickly our guidelines. And these are called rapid practice guidelines. This is one of the reasons for the title of my talk, Rapid Guidelines on Temperature Control. And this process is very similar to the one used by ILCOR. It's a great compliant process that also includes a review of the evidence based on PICO questions, the production of evidence profile tables, and an evidence decision framework, a discussion between a balanced review group, and then the production of the evidence and a recommendation based on evidence according to grade. Another part that facilitated the process is the fact that part of the working group that produced these rapid practice guidelines, that includes, of course, members of the European Association Council and the ESICM, were also members of the ILCOR ALS task force. They already worked on the review process that led to the evidence review and co-star of the ILCOR, and that made the process much, much smoother. So we based our discussions on the ILCOR co-star and on the evidence tables, and the group discussed this via teleconferencing and in a series of teleconferences in sequence in order to achieve consensus. And when consensus, in rare cases, was not reached immediately via discussion, we used majority voting to decide the sense and the direction of recommendations. These guidelines, as anticipated by Jerry, apply to a population of adult patients who are comatose after return of spontaneous circulation, so they presumably have a post-cardiac arrest brain injury. And they apply both to in-hospital or out-of-hospital cardiac arrest from any rhythm and from any severity. As I said, we based our recommendations on the consensus on science. We also contributed to produce inside ILCOR, but as always happens, consensus on science is not directly a recommendation. When it comes to implementation, we have to implement and transform the consensus on evidence on a practical recommendation. And this created some originality and nuances as compared to the ILCOR co-star. And the very first point that demonstrates that is recommendation number 1. Actually, the ILCOR co-star did not include specifically a recommendation or a statement regarding the need to continuously monitor temperature in patients who remain comatose after ROSC. But indeed, the panel felt that if we don't monitor temperature, there will no sense in recommending the temperature control after cardiac arrest. So in lack of direct evidence, we made a good practice statement in favor of continuous monitoring core temperature, because this is a prerequisite for implementing temperature control after cardiac arrest. The second recommendation is crucial. We recommend actively preventing fever, defined as a temperature above 37.7 Celsius in patients who remain comatose after cardiac arrest. And actively preventing fever means acting on temperature, which may mean controlling rising temperature before it reaches the 37.7 threshold. And we recommend we recommend doing this for at least 72 hours in patients who remain comatose. This recommendation comes out from two main considerations. The first one is that in the TTM2 trial and also in the previous TTM trial, even if a bit more indirectly, temperature was controlled for 3 days after resuscitation from cardiac arrest. And the second one is that the timing, the evolution of the hypoxic ischemic brain injury after cardiac arrest, that the temperature control is meant to protect from, evolves during the first 3 days after cardiac arrest. So it's partly immediate and partly the result of evolution after resuscitation. And prognostication also follows this general rule. So it makes sense to control temperature for at least 3 days after ROSC. Recommendation for number 4 is how to achieve temperature control. This can be achieved by exposing the patient, controlling the room temperature, using antipyretic drugs, and or using a cooling device with temperature set at 37.5 degrees. Recommendation number 5 can be split in 2 parts. The first one is that there is insufficient evidence to recommend now for or against temperature control at 32 to 36 degrees, a temperature range that can be grossly defined as hypothermic temperature control. And the second one is that we recommend not actively rewarming mildly hypothermic patients after ROSC. This recommendation was included because there was a concern that rewarming and the patients who are already spontaneously hypothermic after ROSC may cause harm. Recommendation number 6 is that we recommend not using hospital cooling with rapid infusion or large volumes of cold intravenous fluids immediately after ROSC. This is a confirmation of the previous recommendation, not only in 2021, but also in 2015, and was based on the same evidence. Randomized trials showed that infusion of these large volumes of fluid has a potential harm, mainly due to the risk of developing pulmonary edema due to the large fluid load after cardiac arrest, which can be combined with myocardial stunning due to resuscitation. So the knowledge gaps that now remain to be addressed after these guidelines are numerous. The first one is that there is no evidence that normothermia or fever prevention is beneficial versus no temperature control, but probably the upcoming TTM3 trial will address this question. Another very hot question is that if there is any benefit for specific patients. So the panel was in favor of considering temperature control at 32 to 36 degrees as not contraindicated, but allowing this temperature control to be made in case the physician felt that they can be beneficial for some categories of patients, even if there is currently no solid evidence in favor of that. So we left the door open for this treatment, even if we are not directly recommending anymore. And one potential subpopulation that can benefit from this treatment is in hospital cardiac arrest. Just I remind you that the Hyperion trial on non-shockable rhythm showed a potential benefit for temperature control, and this, according to the very recent sub-study, was more evidence in patients resuscitated from in-hospital cardiac arrest. Another potential point should be cool down patients according to greater or lower severity, but as Niklas showed you, at least according to data from TTM2 trial, there is no evidence for it, even if it may be in theory a rationale for this. A third point is the implementation. There is no evidence supporting specific sedation strategies for temperature control after cardiac arrest. And there is, at the moment, no evidence, but I wonder if the TTM3 trial also will address this question, whether a different temperature control will impact prognostication, because generally temperature control aimed at normothermia implies less sedation or curarization rates as compared to the previously recommended hypothermia. And this can affect both the accuracy of prognostic tests or the way prognostication is implemented. I thank you for your attention.
Thank you so much for your interesting talk. And it's also really helpful because obviously the summary allows the kind of clinical straight away to apply it clinically. All the also maybe junior colleagues who are listening in probably start to correlate to what they have been seeing in clinical practice, and all the questions you've or critical points, discussion points you've mentioned is probably the thoughts people have had. I haven't seen anything specific on the slide, but I'll look back into it. I've got a personal question. So looking from a practical point of view, you've mentioned obviously the recommendation 4 on your 10th slide, where you says when you said exposing patients using antipyretic drugs and also the cooling devices. So focusing on the clinical point, what antipyretic drugs from your experience work best and have been used in this trial, if we can emphasize that, and also what cooling devices, because there are some implementation difficulties for them as well, and also some potential skin burns or complications which can happen when you do apply them. So I'll be interested to hear your opinion on this.
Mm-hmm. So your question is whether cooling using patient exposure or drugs versus cooling devices is advantageous in terms of rates of complication. Yes, it's probably easier, as we know. Cooling devices like pads to be placed on the patients at a very, very low risk of complications, but intravascular cooling devices for which there is a trend towards a potential benefit according to literature, even if this is not significant, have instead a significant risk of complications. So cooling using drugs, even if drugs can be harmful, or cooling ambient temperature can be probably safer, even if there is no direct evidence in favor of this, and is probably cheaper. And this is one of the reasons in favor of temperature control aimed at normothermia versus hypothermia. If you consider that in TTM2 trial, in the control arm, the cooling device was used only in 46% of patients. So the majority of patients did not have any cooling device at all.
And pharmacologically, considering pharmacodynamics and kinetics change as well, if you've mentioned that pooling of blood affects as well, do you see any critical aspects in this, especially because, I mean, these patients have multiple problems, not just potentially their cardiac arrest, but also the issues leading to the cardiac arrest, to aim at treating those underlying causes?
Mm-hmm. So you mean that the drug treatment can have side effects, for instance, linked to for instance, if the cause of cardiac arrest, if you have acute kidney injury after cardiac arrest, and you use a drug that has can be harmful for the kidney, this may represent an issue. So the choice of the drug can be carefully made in order not to increase harm or post-cardiac arrest organ injury.
Yes, and I guess the guidance in terms of drug dosing during hypothermia is a difficult question to ask, because there's not many sufficient evidence for any medication we use.
Yeah.
Isn't there?
Yes, we didn't recommend any specific medication for that. And besides the choice of sedation, also the treatment in order to maintain normothermia is not part of the recommendation. So there is no specific recommendation on how to achieve that in lack of specific evidence, hopefully in the near future.
Thank you very much. So,
thank you.
Jazz, would you like to take over?
Yes, thank you. Thank you, Anna. Thank you, Claudio. Tino, are there any questions? And I just remind the audience, you can ask questions. So I'm going to, while Tino's looking, I'll ask Niklas a question. What's the plan for TTM3?
I should unmute myself. Thank you, Jazz, for that question. And it's nice that everyone talks about this trial that has not been started yet, and the protocol is not totally finalized, but we have received funding. And the idea with TTM3 is to try to elucidate a little bit about two of these knowledge gaps. One being the problem with both TTM1 and TTM2, that we did not have a control group, so to say, since both groups were actively intervened with, even if we did it in less patients in the TTM2 trial, 46% having a temperature device. But with the very neutral results of the TTM2 trial, we think that it's mandatory to perform a trial where we randomize temperature control with fever management devices compared to not using these devices. And that has an obvious economical aspect also. If we perform interventions, they should be advantageous. And the second one that we will look into is one of the other crucial knowledge gaps, and that is sedation, whether we should use this type of protocolized sedation for 36 hours that's been part of the TTM package, and that we sometimes believe is beneficial, but we don't know. So we will randomize an as early as possible wake up to protocolized sedation. But obviously, as we all know, working in intensive care, we will use sedation in both arms if it's needed for patient care.
Thank you. At what temperature do you start getting worried then, Niklas? You know, if there's no temperature control?
And I can say that that is probably the thing that we're discussing before the protocol can be sent out. And it's interesting to see, when we started to discuss the TTM1 trial, we ended up that 36 was the absolute maximum we could go to. In the TTM2 trial, when we discussed, after long discussions, we ended up with this definition of 37.7, 37.8, which was based on these 35,000 patients that were presented in British Medical Journal, a normal population, just to see if this was the upper normal limit. So it is a sensitive issue compared to many other interventions. It's much more sensitive when you start discussing it with people. And I wonder if it's because that you feel bad when you have a high fever, and that is why we don't want that for our patients. But if we look into randomized data, all in all adult patients, all indications, all types of fever prevention, there is less than 6,000 patients randomized. And the quality of those trials, the majority are very, very low, and you can't even find out any hard outcomes in these. So it's 2,500 patients that have been randomized all together, comparing fever intervention with no fever intervention. And if you look at the point estimates, it's actually favoring not treating fever. But that's for all indications. So
okay, you haven't given me a number yet. Give us a number. It could be your number, not the TTM3 number. Give us a number.
A number that where I'm would be worried myself. Yeah, in my unit, we have 39.5 as the trigger for starting fever prevention in any case for other patients than cardiac arrest patients. And my take is that we should treat this population as any other ICU patient until we know better.
Okay, thank you. Tina.
Yeah, maybe there's a question which is related to this. There's a question about interventions on temperature management in low resource settings. So I understand the questions. What are your recommendations? What I know is that surface cooling is not such an expensive way of cooling. All the interventions with catheters are quite costly. So what can a person do with little resources to cool patients?
Yeah, well, I think that Niklas can add a few details about the TTM2 trial, but according to the authors of the study, for instance, so even cooling at ambient temperature with air conditioning was used in order to facilitate temperature control. So this added to ice packs shows you as temperature control can be achieved with very limited resources. And this was an additional reason why, in lack of evidence in favor of one intervention versus the other, temperature control likely costs less. And this will facilitate the implementation worldwide.
Mm-hmm. There's popping up an interesting question. Did COVID affect temperature management in your units? Jerry or Niklas?
No. I was just trying to think whether there'd be any impact on that. Not that I'm aware of. No, I don't think that would have changed the way we managed the temperature control of these patients.
Christian, any impact of COVID in terms of managing post-cardiac arrest?
No, not really. At our side, we in Denmark, we had very little COVID at the ICUs. And we don't have it at all. So I don't think it affected any ICUs in Denmark. We had the sufficient place for the patients, and we did business as usual. And on top of that, I was chair of our local resuscitation council, and we also decided that we should not change our guidelines for how you handle it out in the field during this period.
Mm-hmm. Okay. Anna, any other questions?
There's a question about, because the studies were all around 20-25 minutes of cardiac arrest and then intervention. There's a question about longer time, ROSC times of 40 minutes. Are these patients out of any temperature control or interventions? Or what are we going to do with patients having longer resuscitation times?
Niklas?
I mean, of course, the survival for those with very long resuscitation times is very low. We know that, everyone. And there are, of course, case reports where we have been performing CPR for hours with good results. But for the majority of patients with that type of ischemic time, the result will be dismal, whatever we do. But based on the findings from the TTM1 trial and TTM2 trial, there is no differentiated effect whether the arrest is very long or short. So I don't think that we can issue recommendations specifically for the long arrests.
Okay.
It's probably worth, Jazz, it's probably worth just giving the sort of, just to be devil's advocate, the opposing view. And why did I say why do we have so much debate about leaving the door open for colder temperatures? And I think the strongest evidence that's presented today, which is not as strong as randomized data, are two observational studies, one from Pittsburgh, one from Japan, where they've looked and analyzed patients judged based on scores that suggest the severity of their hypoxic ischemic brain injury. And the bottom line is that they seem to show a beneficial effect in the sort of middle group. So the group that are either don't have a sort of mild hypoxic ischemic injury where it would make a difference, or indeed don't have such a severe injury that whatever you do doesn't make a difference. And they've argued using all sorts of statistical analysis that middle group of moderate potential hypoxic ischemic injury may benefit. But of course, as Niklas has said, that's not been shown or been drawn out by the TTM2 trials. But that's probably the strongest data that there are for supporting potentially other patients that may benefit.
Okay, Anna, any questions, or Anastasia? Natasha, sorry, do you have any questions?
There's one question on the Q&A stating that if patients become accidentally hypothermic, especially in the pre-hospital environment outside the TTM modalities, also he specifically stated temperatures below 30 degrees, which is obviously quite critical. Should we then start rewarming patients? And I think that's partially self-answering question, but I'll open the floor to anyone who wants to reply.
Claudia, did you get that? So if someone's hypothermic, guidelines currently support warming them if they're very cold and not warming them if they're not so cold. Do you want to say a bit more about that?
Yeah, I think their recommendations are already there. We recommend not to actively rewarming patients that are already within the previously recommended range of treatment, hypothermic treatment. But of course, for all these patients with extreme hypothermia, the general advanced life support recommendations apply.
Great. Okay, Natasha, any questions?
I was going to ask something that partially was already answered by Professor Nolan. What about the subpopulations that we might think of go ahead and initiate temperature management, if there is any? For example, if bystander CPR was not performed, do we initiate temperature management? Is there?
Yeah, I mean so Jerry, then Niklas, and then Claudio for that one.
I mean, that's partly covered by the sort of comments around those observational studies. But the other things that sort of experts are saying, you know, is that the patients enrolled in the TTM trials, you know, are not representative of our patients, because we see a lot more non-cardiac cause, you know, asphyxial cause of cardiac, and we believe that they benefit from hypothermic temperature control. But as we said, the evidence for that is not strong. But that's the kind of other groups that they are suggesting that we don't have strong evidence for one way or the other. And I don't know whether that's true, but I'm just giving you what they would argue.
Okay, Niklas, yeah, what about all the patients in the excluded groups and asphyxial arrests and all these other groups? Do those groups exist first?
Yeah, absolutely. They do exist, these patients, and I would say that they are not studied, and that we should not perform reverse arguments that if it's not studied, we can use it. I mean, that's a bit of a backward reasoning, I think. So I would say that if we think there is reasons that it should work, then we should study that. And that was partly done in the Hyperion trial, even if it is on the small scale. And just looking at the data, even before we perform the meta-analysis, we can see for the non-shockables, it looks like at least those with out-of-hospital cardiac arrest look very similar to the TTM2 non-shockable rhythms. And I would say that not having done the analysis, it would be a neutral results even for that group. And that was a group with a high number of asphyxial cardiac arrests and other types. So I would say if we believe it should work, we should study it.
Yes. Also, we have more and more patients with ECPR. Do you see any reason to start also temperature treatment with this kind of patients?
Well, if you're using ECPR, you already have a device. You place that device in, so you don't have to worry about complications apart from the natural complications for placing a device in a situation like this. And you have immediately the instrument to perform optimal temperature control. I have to add that a few years ago, we performed a meta-analysis showing that the rate of brain death in these patients, those associated with eCPR versus conventional CPR, was from 4 to 5 times higher. So presumably due to long resuscitation times, these patients have a high severity of hypoxic ischemic brain injury. So if there is a population in which you should consider a neuroprotective strategy, this is the population, definitely.
Yeah, the other thing we should add, of course, is if you look at the animal data, and it was a very nice sort of systematic review meta-analysis that Jasmine and Eric did. If you look closely at that, you know, all those animal studies, they were either cooled, well, the maximum sort of length of time it took to get them to target temperature was 1 hour after ROSC, all something like 48 studies. So if there's one way of getting the temperature down extremely quickly, if you can get people on eCPR very fast, it is just possible that cooling people so much more rapidly rather than the inevitable 5-hour delay that we get in clinical practice may make a difference.
Yeah, I think that's an extremely valid point, Jerry, because what we have been looking at in the TTM 1 and 2 trials and the Hyperion trial and other trials is the type of TTM we have been dealing with for 20 years. And I think we can be pretty sure to say that it doesn't seem to be very efficient. But if we look at the animal data, it's the critical time point from ischemia to start of the intervention. And I mean, basically we should start during ischemia. So I think this suspended animation and very, very early start of cooling, those are the directions you should look into, and not keep repeating what we've been doing for 20 years. That's probably not very efficient.
Okay, thank you. Anna, any more questions?
No, because I would go to the take-home points now, I think. That's all right with everyone. Take-home messages from the speakers.
Okay.
Yeah.
So take-home messages, Niklas?
I think what I just said, I think for the time being, it's reasonable to use fever prevention, but I think we should study that and see if it is at all beneficial. And if we should look into hypothermia for cardiac arrest patients, we should look at earlier, much earlier and more efficient cooling. And probably we should study the in-hospital cardiac arrest group and other types of patients that not have been part of clinical trials so far.
Right. Christian?
Yeah, if I should say something about the cardiovascular system, that would be that if you choose to cool someone for whatever reason, and you end up with a low cardiac output and a low heart rate, don't increase it. As long as the lactate stays or are falling and things are looking fine, don't interfere with the homeostatic system there. You won't do the patient any good. So as long as you see clearance of lactate or whatever you do as your quality measure, don't try to increase the heart rate or increase the cardiac output. It won't do the patient any good, I'm quite sure.
Okay, thank you. Jerry, Nolan?
Yeah, for me, I think the take-home message is, you know, normothermia, preventing fever. I'm still not entirely clear in my own mind exactly how we do that in practice, because, you know, we have yet to implement this locally. We're still targeting 36 at the moment. So for me, it's about working locally how you are actually going to achieve that normothermic control until such time as we have data to prove one way or another whether that is actually effective in any case.
Thank you. And Claudio?
Well, I would like to echo what Niklas did say. So definitely in-hospital cardiac arrest represents a population to be investigated in the near future, and the faster cooling has a potential to demonstrate benefit in the future if we manage to achieve it.
Thank you. I'd like to end this webinar on temperature control after cardiac arrest. I'd like to thank our speakers and my co-chairs. So thank you all very much. Before we sign off, I want Francesc, who's been coordinating this to just tell us a bit about some more webinars that the ERC are going to be holding in the future.
Good night to everybody. I'm Francesc Carmona. I'm a physician in the emergency medical system in Barcelona in Spain. And since the end of the past year, the education co-chair of the ILS Science and Education Committee, and also the coordinator of the webinars. First, thank you all for watching this webinar in streaming, and also thank to all of you that will watch it later. And also thank to all of these fantastic panelists and moderators that we have had today. The ERC want to spread resuscitation knowledge, and for this reason has created this platform similar to the online Congress platform for webinars. And we have planned monthly webinars every last Tuesday of the month, starting for this webinar about temperature management. The next webinar will be, I will share my screen and I will. Okay, the next webinar will be the next April 27th, led by the Instructors and Educators Support Science and Education Committee. They will talk about how to teach skills for resuscitation. The following webinars will talk about pediatric early warning scores. Then there will be a pause for the Congress. Just will talk about it in 1 minute after me. And then we will have a webinar in July about the World Restart a Heart Day to give time people to collect ideas for October. Then the people from the Basic Life Support Science and Education Committee will talk about virtual reality as the future of CPR training. Federico Semeraro is a very, very interested guy in this topic. Afterwards, in October, we will have a webinar about neonatal life support in out-of-hospital setting. And in November, we will end the year with CPR teaching in low-resource settings. And in December is Christmas, and it will be free of webinars and free of any. I have lost my screen.
Education.
So, I have lost my. Okay, now thank you, Lars, because you have ended my screen. And after this, I give the word to Jess to talk about the Congress.
Thank you. So just one more thing. And in June, the ERC is going to have its first face-to-face conference. So it's June the 16th, 17th. It's a Thursday, Friday. It's in Antwerp, in Belgium. We're doing it face-to-face, but if you can't make it face-to-face, there'll be a virtual option to join. So it's a hybrid meeting. We have a very, very good faculty there. So we've got lots of excellent speakers. It's about implementation of guidelines. So you'll see some of the speakers who've been on today. We've got faculty from all over the world. Teresa Ollersvegen is doing the Sapphire lecture. Marcus Griffars is doing the Nagofsky lecture. We have sessions on equity and equality, COVID, advanced life support, basic life support, children, newborn, and a wide range of aspects. We also have joint sessions with partner organisations, including the European Society of Cardiology, the European Society of Emergency Medicine. We have first aid sessions. So it's going to be a great meeting with lots of opportunities for networking. And if you want to attend the meeting, please visit the website, www.resuscitation.eu. Thank you. I'm going to stop sharing for now and take another chance to thank you all for joining. Thank you to all our panel members. Look forward to seeing you at future webinars and face-to-face at our meeting in Antwerp in June. Thank you.
Thank you.
Thank you, everyone. Take care.
Bye. Thank you.
Bye.
Bye, everyone.